Good morning, everyone. Respected chairpersons for this session, Dr. Rajkumar, Dr. Abhi Matthew, moderator of the session, Dr. Sri Santosh Yanda, and my dear students. I welcome you all on behalf of Indian Prosthodontic Society for today's session of IPS exam preparation about prosthetic rehabilitation of mandibular defect. I am thankful to IPS head office for this opportunity, and my special thanks to Dr. Sesha Reddy and Dr. Hari Priyanka for arranging this session on prosthetic rehabilitation of mandibular defects. So, as we are aware that mandibular defects, they may be because of various reasons, which include traumatic injury, surgical resection of the tumor, and it may be because of certain etiologies which necessitate resection of the mandible. So, prosthetic rehabilitation of mandibular defects due to surgical resection or trauma is usually very complex procedure. Rehabilitation is the process of getting back to healthy or better lifestyle, or the procedure of assessing the patient to do this. Mandibular defects induce paradigm shift in the lifestyle of patient due to functional, biological, aesthetic, and social consequences of the treatment. Augmentation of the understanding and advancement of new technology has fostered the rehabilitation of these defects. Interdisciplinary approach is essential for successful rehabilitation, which includes surgical intervention, radiation therapy, and or chemotherapy followed by prosthetic rehabilitation. Patients with post-surgical defects can return as close to normal if all possible and constant customized modifications are made precisely. Apart from that, it may also necessitate additional surgical procedures to improve the treatment outcome. Surgical reconstruction of the defect with free fibula graft, pedicle bone graft, particulate bone cancellous marrow grafts, and reconstruction plates along with microvascular free flaps is possible, where these procedures involve harvesting of bone and soft tissue from the donor sites. Among all these procedures, surgical reconstruction with microvascular free flaps is considered most recent. There are chances of significant morbidity which can affect acceptance of treatment by the patient. Diagnosis and treatment planning should be executed in a precise manner to improve the prognostic factor. Curtis and Cantor in 1974 mentioned regarding problems associated with treatment planning of mandibular defect. Recent advances in the field of surgical reconstruction and prosthetic rehabilitation have improved the treatment outcome as compared to clinical procedures in the past. It is essential to assess various clinical situations associated with mandibular defects and treat appropriately to improve the quality of life of this patient. As we can see, there are various muscle attachments which are visible in this photograph. And when there is a resection of the mandible, these muscle functions they get compromised, and it leads to deviation of the mandible, and it gets deviated to the resected side. Now, there are various classifications regarding these mandibular defects. Before that, we need to understand that prosthetic rehabilitation for restoration of normal function as well as aesthetics is a principal challenge in the rehabilitation of patients who have lost their teeth and part of mandible after surgical resection of cyst or tumor. Wherever the extent of edentulous span and length of defect increases, rehabilitation with fixed or removable prosthesis become further complicated. Anatomic deformities, in addition to adverse biometrics in the proximity of resection area, add to incongruence. Apart from that, disabilities resulting due to resection often lead to loss of mandibular continuity, which further leads to facial disfigurement, uncoordinated movement, and difficulty in chewing, as well as impaired speech and frontal plane rotation. We're going to see how does this frontal plane rotation takes place in upcoming photographs. So Uh, the most commonly followed classification of mandibular defect, it was suggested by Cantor and Curtis. It includes six different classes. Class 1 includes mandibular resection involving alveolar defect with preservation of mandibular continuity. Class 2 involves resection of a defect, resection with defects involving loss of mandibular continuity distal to the canine area. Then class 3 is resection of defect, which involves loss up to the mandibular midline region. And in case of class 4, resection of defect involves the lateral aspect of the mandible, but is augmented to maintain pseudo-articulation of the bone and soft tissues in the region of the ascending ramus. In case of class 5, resection defect involves the symphysis and parasymphysis region only and augmented to preserve bilateral temporomandibular articulation. So basically reconstruction is done in this class 5. And in class 6, it is similar to class 5, but there is no mandibular continuity because the reconstruction procedure is not done in this particular class. So this is the photographic representation of various defect, that is class 1 to class 6 suggested by Cantor and Curtis. So we can see in this particular defect where the resection of mandible has been done, but the continuity has been maintained. So we do not find any kind of deviation of mandible because the continuity is maintained. And comparatively, we can have easier options for rehabilitation of such defects. When the defect is extensive, then in that case, we may have to go for segmental resection, and segmental resection will lead to loss of mandibular continuity, and there will be deviation of the mandible. So this deviation is towards the resected side of the mandible, and we can see that in this particular area, in the anterior region, there is rotation of the frontal plane. So there is lack of occlusion in the anterior region because the frontal plane rotation takes place after resection of mandible due to loss of muscle imbalance or due to loss of muscle balance, that is muscular imbalance. Apart from that, there is limited mouth opening, and this limited mouth opening is by virtue of resected soft tissue, and there is no appropriate reconstruction of the lost soft tissue, and it leads to stricture formation and fibrosis of the surgical site. And apart from that, most of these patients, they undergo radiotherapy in a later phase, and this radiotherapy will further increase the fibrosis and it will lead to trismus or reduction in the mouth opening. Now, this is again another case where the segmental resection of the mandible has been done, but it has been reconstructed with reconstruction plate. So in such cases, the occlusion can be restored, the deviation can be prevented, and other clinical features like frontal plane rotation, they will not be visible. Then, as we discussed initially, there will be another option in the form of resection of mandible and reconstruction with free fibular graft. So, free fibular graft, it will help to maintain the continuity of the mandible, and it will prevent the deviation and restore the function in a limited period of time. We can see that there are two layers of free fibula graft, and this technique is called as double barrel technique. Uh, Again, this is another case where the lost mandible has been reconstructed with free fibula graft using double barrel technique. So basically, whenever there is excessive vertical height, it will lead to failure of the prosthesis. So just to avoid this vertical cantilever, we can use this double barrel technique, and it will help to improve the prosthetic prognosis. Then, as we discussed, whenever there is segmental resection or hemimandibulectomy, it is called as discontinuity defect, as there is loss of continuity of the mandible. Such cases need rigid reconstruction after hemimandibulectomy, And hemimandibulectomy with discontinuity defect affects the muscular balance of facial muscles, leading to disfigurement of face if reconstruction is not done. Such cases are really usually reconstructed with reconstruction plates. The most extensively documented classification system is the SCL classification by Jouer and colleagues. This SCL classification was amended by J.B. Boyd and colleagues with addition of three lowercase letters like O, which is neither skin nor mucosa, M, that is mucosa, and S, skin, which represents epithelial involvement. So in this radiograph, we can see that the hemimandibulectomy has been carried out. And in such cases, it is essential to reconstruct the defect. Otherwise, there will be excessive muscular imbalance leading to affected quality of life of such patients. Again, there has been mention of several mandibular defect classification. Pavlov has classified mandibular defect into three classes, and they are depending on the number of residual bone fragments. David and colleague have given the classification of six types of defects, which is based on the segments of dissected mandible. In 1991, Erkane et al. Proposed a widespread classification of mandibular defects on anatomical, functional, as well as aesthetic considerations. The classification consists of mandibular defects, symphysis, uh, uh, R, that is ramus, C for condyle, and B for body. Soft tissue defect in addition to neurological defects are considered in this classification. Then Lizuka and colleague classified the resection of mandible into four classes centered on osteotomies for mandibular free fibular flap reconstructed with help of endosseous implants. Then Hashikawa and colleagues suggested that CAT classification in the year of 2008, which was illustrative of loss of condylar head, that is C, angle, that is A, and the mental tubercle. The hemimandibulectomy was symbolized as CAT. In 2011, Baumann, DP et al. Suggested a classification of the mandibular bone defect resulting in osteoradionecrosis into four types, with type 1A, type 1B, and type 2A. The type 2B in the reference to loss of condyle, mucosa, and overlying skin. Segmental mandibulectomy, that is a discontinuity defect. These defects affect function as well as aesthetics extensively after resection of mandible due to lack of continuity after resection of mandibular segment. So you can see there is loss of continuity in this there is en bloc resection of the mandible. So that is segmental resection of mandible. Again, it is another case where the segmental resection of the mandible has been carried out. Now, regarding the goals in reconstruction of mandible, there are three basic goals when there is planning for reconstruction of the mandible. The first one is to provide architectural support. Second one is restoration of the facial contour. And third one is preservation of the occlusion. Apart from, there are additional challenges like osteoradionecrosis, as these patients usually undergo radiotherapy. So there will be a necrosis of the soft tissue as well as bone, and we may have to face failure of implants in such cases. So it is very essential to plan implant supported prosthesis after careful assessment of these cases, and otherwise it will lead to failure of the implants. So we need to take care of trismus also, because if the mandibular deviation and the mouth opening which is restricted due to trismus, it will affect the prosthetic planning as well as prognosis of the prosthesis. Now, regarding the discontinuity of mandible after resection, as we already discussed, it will lead to mandibular deviation towards the surgical site. It will distort balance as well as symmetry and leads to altered mandibular movements. It clinically results in facial asymmetry and malocclusion, and we see the frontal plane rotation. So that is why the resection followed by immediate reconstruction is recommended. So the patient will not have to face all these problems, and the quality of life can be restored up to the maximum best level. Again, this is a case where the mandible, it was resected, and it may be a segmental resection extending over a longer span, or there will be a soft tissue as well as the hard tissue, and this defect may be very small. So such smaller defects, they can be reconstructed using free fibula graft, and that is the basic advantage of free fibula graft, where we can reconstruct a smaller segment as well as a larger segment, as we have maximum 25 centimeter length of fibular graft which is available for rigid reconstruction. Again, this is a case where we may have to go for extensive resection of the mandible, and it will require a resection followed by reconstruction of hard as well as soft tissues. And if it is not reconstructed, it may lead to such kind of soft tissue defects, which will need rehabilitation of mandibular as well as additional facial defects. And this is what we were discussing about. You can see that there is extensive frontal plane rotation, as there is a resection of the mandible towards the left side. And apart from that, as there is uh, loss of contact, there will be supraeruption seen in few cases where usually in posterior region where the opposite teeth, they are out of contact, and that is why the occlusal rehabilitation or the occlusal restoration, it is equally very important in combination with rehabilitation of these mandibular defects. Now, this is a video where we can see that there is deviation of the mandible in combination with frontal plane rotation. So, you need to plan in such a manner that these defects will be restored in an optimum manner. Now, regarding the management protocol, whenever there is a mandibular defect, there are certain protocols which need to be followed. The first management option is intermaxillary fixation. So it helps in maintaining the proprioceptive sense of proper interocclusal position during the initial healing. That is for the period of 5 to 7 weeks, and it is effective when there is minimal loss of tissue. Then second treatment option is guidance prosthesis. So in case of guidance prosthesis, there are two options again. The guidance prosthesis, it can be from palatal origin, that is a one-piece guidance prosthesis, or it can be a two-piece guidance prosthesis, which is called as mandibular origin guidance prosthesis. These guidance prostheses, they are used on interim basis until acceptable occlusal relationships and proper proprioceptions are not re-established. So this is a single piece guidance prosthesis which is having the palatal origin. So you can see that there is a buccal plate and palatal plate. So palatal plate basically offers support, and it provides resistance, as the mandibular deviation will get corrected, but at the same time it will exert force on this guidance prosthesis. So it should have adequate rigidity as well as stability, so that the muscle pull or the muscle force exerted by mandibular muscles, it can be countered with the help of this prosthesis. So sometimes you need to combine this guidance prosthesis with a removable partial denture. So it's a combination of removable partial denture and guidance prosthesis where we can replace the missing teeth. And at the same time, it will act as a guidance prosthesis to correct the deviation of mandible. So again, this is another type of guidance prosthesis that is from the mandibular origin. So you can see that it will help in guiding the mandible in proper interocclusal position. So this is another guidance prosthesis, and it is a two-piece guidance prosthesis, and it has mandibular origin. But at the same time, the second part of the prosthesis, it is in the maxillary arch. It will provide a ramp, and the mandibular guidance prosthesis, it will slide against the ramp which is available uh, with this maxillary part of the guidance prosthesis. But at the same time, there are certain difficulties while prescribing this prosthesis, as it will need a, appropriate or adequate mouth opening. And if you come across patients who have deficient mouth opening or there is trismus, then this two-piece guidance prosthesis, it will be difficult to prescribe, or it will be difficult for the patient to use this kind of prosthesis. So this is how it looks when it is inserted in a patient's oral cavity. So there is a ramp on the buccal aspect of maxillary part, and the guidance prosthesis, it will slide along this ramp and it will achieve the maximum intercuspation. So this is another case where we had planned the guidance prosthesis. So I'm going to show this first video where you can see that the frontal plane rotation is there, and apart from that, there is deviation of the mandible. So we planned this guidance prosthesis for restoration of uh, the occlusion, and this second video shows that the guidance prosthesis has been inserted and the patient can close appropriately, and the loss occlusal equilibrium, it has been restored with the help of this guidance prosthesis. So the occlusal equilibrium has been established with the help of this guidance prosthesis. Again, this is another case. So you can see that the patient can close appropriately and the deviation has been corrected with the help of this uh, guidance prosthesis, which is having palatal origin. So guidance prosthesis is a maxillary or mandibular conventional prosthesis designed for the patient who is able to achieve an appropriate mediolateral position of the mandible but is unable to repeat this position consistently for adequate masticatory function. So this is another case where the guidance prosthesis has been fabricated to achieve the occlusion. Now, when to plan a guidance prosthesis? Fabrication of guidance prosthesis can be done on preoperative models prior to surgery after determination of extent of resection, and prosthesis fitted immediately after post-surgical sequelae have subsided, or after 15 days post-surgery, which is ideal time, that is 2 to 4 weeks, and definitely before initiation of the radiation therapy, because once the radiation therapy will start, there will be initiation of the fibrosis, and it will lead to trismus and other complications related to oral cavity. So in a few cases, there will be resection of the mandible and the patient is completely edentulous. So in such cases, it will be very challenging to achieve the occlusion. And for such cases, we can have the guidance prosthesis in the form of uh, additional row of teeth which can be incorporated in the maxillary arch. So the patient will be able to bite with the help of these additional teeth which are there on the palatal aspect. And as we know that the correction will be a bit difficult as there are no teeth present, and there is issue related to stability. So we can have this kind of processes which will help the patient to have some extent of mastication possible due to this additional row of teeth present in the maxillary prosthesis. Then so the next option is intensive physiotherapy and other medicines to reduce the fibrosis. So it includes the prosthetic management as well as exercise program, and it should be started 2 weeks after the surgery. These movements tend to loosen scar contracture, reduce trismus, and improve maxillomandibular relationships. So we can have these tongue blades. They can be used to execute the exercise program. And apart from that, there are certain dynamic bite openers in these forms. They can be used to help the patient in increasing the mouth opening. Apart from this dynamic bite opener, there are certain injection, that is, they are intramucosal injections which can be used, such as hyaluronic acid or certain steroid injections, and they may help for increasing the mouth opening. Then the next option is reconstruction of the mandible with reconstruction plates. So they will help to restore the mandibular continuity immediately, and the occlusion will get re-established immediately after resection of the mandible. And the patient will not face difficulties like loss of occlusion or frontal plane deviation, and deviation of mandible to the resected side. So we can see that after reconstruction also, the patient needs to be followed at a regular interval, as these patients, they will undergo radiotherapy, and there are certain side effects of radiotherapy, and these patients need to be followed at a regular interval. Then once the mandibular discontinuity is restored by reconstruction plate, we can think about various options like cast partial prosthesis for restoration of occlusion. So in this case, the reconstruction was done, and cast partial framework was fabricated, and it will help to restore the lost teeth in the resection area. Apart from that, these soft tissue flaps, they will also help to restore the lost soft tissue structure. But at the same time, there are certain drawbacks of only soft tissue reconstruction. That is why it is always recommended to incorporate soft as well as hard tissue reconstruction by using certain bone grafts. So the vascularized bone flaps proved to be superior compared to previous methods, and rib, ilium, radius, metatarsal, scapula, fibula, these grafts have been used over the period, and they have become very effective. And the fibular graft, it was popularized by Hidalgo in 90s, and nowadays it is considered as one of the most acceptable treatment option for reconstruction of mandible. So as we have already discussed how this reconstruction takes place with free fibula graft, and there are different techniques like double barrel technique, and it will help to reduce the vertical cantilever. So this fibular graft, it will be effective in case of resected mandible where the patient is undergoing radiotherapy, as the fibula is having a better vascular supply as compared to the native mandible. And that is why the rate of osseointegration is comparatively better than the mandible. And that is why it can be considered as an option where the implant supported or implant retained prosthesis is being planned after resection of mandible. So this is another case where the reconstruction has been carried out with free fibula flap, but we can see that there is excessive bulk of the free fibula. And that is why in most of the cases there is a requirement of debulking to reduce the excessive bulk, and there may be requirement of hair removal also, because hair keep growing constantly. So debulking will help to minimize the prosthetic challenges. So this is how the planning is carried out for reconstruction of the lost bone. And we were discussing about fibula. So fibula is having very rich vascular supply. It is in the form of peroneal artery, and that is why it is considered advantageous for reconstruction. Apart from that, it has sufficient length to reconstruct. It allows two-team approach. Low donor site morbidity is there. Abundant periosteal blood supply that permits multiple osteotomies. Addition of a skin islands allows for absolute tension-free intraoral closure, enhancing tongue mobility, and bicortical stabilization can be achieved with free fibula graft. So this is how the free fibula graft it will be osteotomized, and it will be used for reconstruction of mandible. Then the length can be taken as per requirement. Whenever there is a smaller segment, we can have a small graft, and whenever there is extensive resection, we can take up to 25 centimeter of length from the fibula graft. Uh, Again, as we discussed, implants can be placed. There are various protocols regarding placement of implants after reconstruction with the free fibula graft. But there is again a drawback of the protocol where the implants are placed at the time of reconstruction, because most of these patients, they undergo radiotherapy, and when implants are there in the oral cavity at the time of radiotherapy, they will lead to backscatter radiation, and the tendency towards osteoradionecrosis is increased. So it will be better to wait for a certain period, that is 6 months to 1 year after radiotherapy, and then we can, depending on the clinical and radiographic assessment, we can plan for implant retained or implant supported prosthesis. So again, this is a case where the reconstruction plate has been used after the fibula was used for reconstruction, and the appropriate shape of the mandible, it can be achieved by precise osteotomy. Then there are certain challenges when we reconstruct the mandible. Most commonly, there is compromised sensory and motor control of the lip, and the bolus manipulation and denture control is difficult due to resection of inferior alveolar as well as marginal mandibular nerve. Then this is a case where there was resection of the mandible due to extensive ameloblastoma. We can see that extensive tumor in this radiograph, and it was planned to resect. So you can see that there is a change in the width of the buccolingual width of the mandible because of this extensive tumor. So it was resected, and the free fibular graft, it was planned, and it was used for reconstruction of the mandible, and the surgical site was sutured. Then the radiographic assessment was done at a regular interval to assess healing of the graft, and then 3D CT guided planning for implant retained prosthesis was done, and then implant placement was done after adequate debulking of the free fibula graft, and this was the implant which was placed, and the site was surgically closed. Again, radiographic assessment was done to uh, examine the progress of osseointegration, and once the radiographic assessment suggested that the further prosthetic treatment planning can be carried out, or the prosthetic treatment procedure can be carried out, the prosthetic rehabilitation was initiated, and there is a important step, that is the centric relation record. At this stage, we need to maintain the vertical dimension comparatively close, because it will facilitate the interaction of the tongue with the palatal structure during speech as well as swallowing. As we are aware that most of the mandibular defect, they are associated with the compromise tongue function. And that is why the centric relation record step, it is very important, and this protocol needs to be followed so that there will be appropriate function of the tongue during swallowing as well as during the mastication. And apart from that, reduced vertical dimension, it will also make it easier for the tongue to position the bolus onto the occlusal table. Then usually the monoplane concept of occlusion, it is incorporated, and reduced vertical overlap of anterior teeth was incorporated while doing or while performing the teeth arrangement. And the ball and cap attachment, it was used as it will be easy to maintain. The hygiene maintenance is comparatively easier, and this was the final processes. And you can see that there was extensive change in the profile of the patient before and after treatment. This is another case where the patient had undergone extensive radiotherapy. He received a dose of 60 gray, and then the radiographic assessment was done post reconstruction of the defect with free fibula graft, and implant return process was planned. So we can incorporate these autografts like PRF, which will help in healing, and it will expedite the process of osseointegration in cases where the patient has undergone radiotherapy. So the implant placement was done, the surgical site was closed. This is again amalgamation of different graft materials. It was combination of PRF, autograft, and alloplast, which was used at the surgical site to augment the bone. And the patient underwent radiographic examination at a regular interval, and the prosthetic procedure was carried out. Ball and cap attachments were used, and then uh, it was relined and picked up in the prosthesis. So the cap attachment, they will be part of the prosthesis, whereas ball attachment, they will remain in patient's oral cavity. So this was the final prosthesis, and you can see the difference before and after prosthetic rehabilitation. Apart from that, we can restore the loss of teeth with simple prosthesis. But in few cases, we may have to reline the prosthesis because there is extensive soft tissue, and it may need soft tissue relining because the food may get trapped uh, under the prosthesis because of that extensive soft tissue. So in such cases, we can go for soft tissue relining, and here you can see the extended lingual flange of the prosthesis. It will help to balance the prosthesis, and during mastication, it will offer additional stability. Now, once the deviation is corrected, definitive prosthesis in the form of partial denture or implant supported prosthesis, it can be given, and it is easier in case of reconstruction with free fibula flap. So you can see it's an implant supported prosthesis after reconstruction with free fibula flap. So this was another case where a full arch prosthesis was fabricated, and again this prosthesis needs to be maintained in a appropriate manner. Oral hygiene instruction should be given at regular interval, and the patient needs to be assessed. Apart from that, there will be some small defects which will be in the body of mandible, and they can be restored with the help of these prosthetic devices, because if that defect is not closed, it will constantly lead to uh, food accumulation and secondary infection. So these kind of processes, they can be fabricated to close the defect and prevent ingress of or entry of the food. Then as we discuss, in most of the cases, there is combination of tongue defect. So either there will be complete glossectomy or partial glossectomy, and these patients may need tongue prosthesis or palatal augmentation prosthesis depending on the extent of resection of the tongue. So palatal augmentation, it will help in lowering the palate and allows tongue to interact with the palatal contours. And it is also called as palatal speech and swallowing aid prosthesis. So in this case, we can see the tongue has been resected partially, and the palatal augmentation prosthesis has been fabricated. And whenever there is complete resection of the tongue, it can be reconstructed with soft tissue flaps. But again, there will be requirement of palatal augmentation prosthesis. And as we discussed, in many cases, there will be a complete resection of the tongue. So we can fabricate this static tongue prosthesis. It will help in deglutition as well as swallowing. So it can be combination of tongue as well as palatal augmentation prosthesis in few cases. So speech assessment can be conducted to assess the outcome of prosthesis in case of mandibular defects. And there are certain recent advances nowadays, and we can use these recent advances for better treatment planning and rehabilitation of mandibular defects. In first photograph, you can see the virtual planning was done for fabrication of a definitive guidance prosthesis, and it was a single piece prosthesis of palatal origin. And after virtual planning, we can fabricate this definitive prosthesis, that is in the cast partial framework. And in second photograph, you can see the 3D printed model. It will help for planning of resection as well as reconstruction. So these models, they are very beneficial for prosthetic planning. Then again, this is another case where the virtual planning was done for rehabilitation of mandible after resection of the tumor. And we usually perform this kind of virtual planning when we plan for resection of the tumor in mandibular region and rehabilitation with free fibular graft. So it will help for precise osteotomy of the fibular graft, and the treatment outcome, that is prosthetic outcome, it will be more satisfactory, and it will help to improve the quality of life in a precise manner. So coming to the conclusion, prosthetic rehabilitation helps to reinstate facial appearance, speech and masticative function, and thus improves patient's quality of life in patients with mandibular defects. For the patient who has undergone segmental or extensive resection of the jaw, reconstruction with free fibula flap and prosthetic rehabilitation with implants improve quality of life. Alter tissue histology, soft tissue thickness, and radiation with lack of oral hygiene are contributing factors for soft tissue dehiscence and peri-implantitis in grafted jaws. These are some of the references. So again, I'm thankful to Indian Prosthodontic Society head office for giving this opportunity. And it was a nice experience to interact with all of you by virtue of this topic, prosthetic rehabilitation of mandibular defects. Thank you.